Good morning, everyone. I am going to speak on the role of prostate MR in selecting candidates for focal therapy. So, at the outset, I would first tell you that I don't have any experience on focal therapy. In my institute, we really don't do focal therapy, but we do a very high volume of prostate MRs. So, what I can tell you is that how good or how bad is MRI in choosing candidates for focal therapy. So, so back in my residency, so when I did my residency in 2014 in TMH, every patient would come to our department for a TRUS biopsy with only a DRE finding and a PSA. That's all. There used to be no imaging done. And now, in a decade, the scenario has completely changed. Every patient who walks into our department for a biopsy has an MRI. We look at the MRI, we read it, we interpret it, we give a PIRAT score, then we decide whether to do a biopsy or not. So the situation has completely shifted in the last decade. And MR, it's pretty good at lesion detection, deciding whether to do a biopsy or not, guide biopsy, and also help the treating team in deciding the next step. So this is traditionally the role of MRI, and MRI is doing fantastically well in this aspect. Now, because MR has, it has become such an important part of prostate cancer management, and the technology has become so good, the scan quality has become so good now, that now we are being asked more questions. So now MR has come into action in deciding eligibility for focal therapy. So this is a new challenging domain that has come up now. And we now have to give answers to whether MR can really help in selecting patients for focal therapy, or whether we can kind of rule out focal therapy in certain set of patients based on MR. So for example, we have a patient comes to our department with a certain PSA level, a certain clinical finding, et cetera, and an MR is done. Typically, we do these two sequences. We do a T2 and we do a diffusion. So as per PIRADS, these two are the basic sequences, and contrast is an optional sequence, which is done in certain situations. And we pick up this lesion. So on the left side of the peripheral zone, there is a lesion. And the question is whether this patient is a suitable candidate for focal therapy or not. Now, can we answer that based on an MRI? To answer that, I will show you a few indications here. So generally, these are the indications. The top ones are all clinical indications. These are pretty tight and specific. If you look at these, these are very, very specific and robust. But if you look at the bottom ones, the ones outlined in red, this is where MR comes into play. So these, we need to know how strong or how poor we are on imaging to tell this information. And of course, there are certain exclusions. This, I think, is the strength of MRI. Whether we are able to select patients for focal therapy or not is a different question. But in these scenarios, we are definitely able to say that the patient is not going to be suitable for focal therapy. So if we on imaging can tell bilateral multifocal clinically significant disease, or if we are able to tell gross extraprostatic extension, or if we can definitely say this patient has got nodal or bone metastasis on the pelvic MRI, etc. So these are the indications, these are the situations where on MRI, we can say that definitely no focal therapy for the patient. So on MRI, I can tell you the lesion size, I can tell you the location, I can tell you whether the lesion is located at the apex, base, whether it's close to the urethra, whether it is close to the neurovascular bundles, etc., etc. This information I can tell you, but how strong we are in giving that information. So before going into that, I will first show you some images like this. So it is very sad that the world is moving to focal therapy, but we are still stuck with poor quality scans. In my hospital, 80% of the workload in prostate MR is the outside scans which get uploaded, and they come from really good diagnostic centers, and these are the kind of images that we get. These are really bad quality, and it is really disappointing to see that although we have clear guidelines, PIRADS guidelines that clearly tell us how the scan has to be done, what should be the slice thickness, what should be the B value and diffusion, etc., etc. We still come across these kind of scans, and it is a big challenge for us to kind of convince our surgical team to get these scans repeated. So if for example, in this particular case, you see, I can see that there is some abnormal area on the T2, but I'm not really sure if there is anything on the diffusion. So the outside report called it a PIRATS 3. That is the usual report. Most of the outside reports that we get, they tend to call lesions as PIRATS 3 because then they can hide behind that particular category. And if the patient gets a biopsy, then they are safe. And if the patient doesn't get a biopsy, then they know that they have still done their job and they've called it a PIRATS 3. So technically they are safe. So that's the typical MRI report that we get. And this is the kind of scans that we get. So then, I convinced my treating team to get a repeat MR. And when we repeated the scan, we can clearly see that the lesion in the left side peripheral zone shows a strong diffusion restriction. So that was a PIRATS 5 lesion. So we scored it from PIRATS 3 to a PIRATS 5. And now this kind of good scan quality, it improves our confidence in calling a lesion a definite suspicious lesion and ask for a biopsy. So this is where a good quality image really helps. And in any institute that is offering focal therapy, if they are coming across these kind of suboptimal scans, they definitely have to repeat a scan, and a contrast is mandatory. So a high quality MR that shows exactly what is going on in the prostate is a must before deciding the eligibility or ineligibility of focal therapy. And this was another case where there was no lesion. So this was actually reported as PIRATS 2 outside, but because this patient had an abnormal DRE and a PSA, we repeated the scan here, and we could easily pick up a lesion in the right side peripheral zone, which shows a strong diffusion restriction. So that's how a good quality MR. So a good MR is the first step in this whole scheme of things. So if you don't have a good MR, you really don't have options to give. You cannot treat what you don't see, right? Second challenge that we face is the margin of the tumor. Now, there have been like a lot of studies that have compared the lesion size on the pathology specimens after radical prostatectomy, and they've compared the lesion size with the MRI, the preoperative MR size, and they have found that these lesions are typically bigger than what we see on MRI. So that's a challenge, and this is kind of overcome partly by increasing the ablation zone in these focal therapy treatment options. But on MRI, can we do better? So we see these kind of lesions, ill-defined lesions. I don't really know where is the margin of the tumor. If you look at the diffusion, ADC, and T2, the lesion size will look different on all, and it has got fuzzy margins. T2, I don't really know. It is merging with the background dark signal of the parenchyma. Then I see there is some focal lesion here. Some part is brighter, some part is not so bright. I don't really know what is the tumor margin. And PIRATS typically recommends measuring the tumor, the maximum dimension of the tumor on the ADC, not on the T2 or on the diffusion. So we don't really know what exactly is the size of the lesion, what is the margin of the lesion, which is where probably contrast has a very, very strong role to play. A lot of studies have shown that post-contrast size of the tumor matches better with the pathology size. And the T2 and the diffusion kinds of underestimates the size of the tumor. So which is why if we are planning focal therapy on any patient, the scan has to be a post-contrast. So we have to do a multiparametric MRI. There is no way out. But if it is for lesion detection and characterization and planning biopsy, then a biparametric MRI is good enough. But for focal therapy, if you want to outline the tumor better and pick up more lesions or look at the lesion better and give a better, clearer margin around it, then you have to do a contrast scan. This is another case where the lesion size is different on all the 4 images. You have this T2 kind of blurry margin, diffusion, ADC, and contrast shows the lesion bigger. So whichever sequence shows the lesion bigger should be considered the size of the lesion on MR. That's the closest that we can come to the pathology. Also, the contrast shows lesions better, which is why there is no option. We don't have a workaround. We cannot afford to do a non-contrast. We have to give contrast in such patients. So if a patient comes to you with a biparametric, you have to repeat the scan and give contrast because the lesions will definitely shine better, and you may even pick up more lesions if you give contrast. So this is another challenge, MR occult lesions. This is where MR really fails. If we have a dominant, so the job of MR is to pick up the dominant lesions in the traditional sense. MR was never made to pick up all possible lesions in the prostate. It was actually, the role of MRI came to pick up the major lesion and decide whether biopsy needs to be done or whether you can avoid biopsy. If there are occult lesions in the other side of the prostate, then we are not good at that. And the only way around probably is to do a systematic biopsy. So we have to do a targeted biopsy for the dominant lesion, and do a systematic biopsy for the rest of the prostate. Uh, Extra prostatic extension, again, we are not really there yet. If there is obvious disease outside the prostate, then MR is really good. So here, this is very obvious extra prostatic. Now, these are big lesions, definitely not candidates for focal therapy, but we are good at this. And also we are good at seminal vesicle invasion. But this is a challenge. In Indian population, this is, I feel, is the biggest challenge, because Indian cancers are big. Patients come later with advanced cancers, aggressive lesions. We don't have screening. So lesions are typically more than a centimeter in size. So we have to call those lesions as T3A. So T3A technically is EPE, because as per the PIRADS document, if I say that it's T3A, it's an indirect sign of extraprostatic extension based on all these broad contact, irregularity, and bulge, etc. So we don't really have any clear guidelines as to whether to consider these as true EPE or not. But I spoke to some experts yesterday. It seems that there is a lot of variations here. The UK group kind of treats this as organ confined, I guess. And then there are Japanese groups that exclude such patients from focal therapy. Yeah. So I'm almost done. So here, this is my concluding slide. So I just want to highlight that the PIRADS logic doesn't hold for the prostate therapy logic. The whole reason why MRI came was as a triage tool. So our aim was to pick up the most aggressive looking cancer and then prove it as cancer and treat the whole gland. But now what we are trying to do is treat each lesion individually. So we are not really there yet. And this is where the role of MR is, to give the margins, detect all lesions, and to stage it. But there are certain limitations, and we have to find ways to work around them. So I will conclude with that. Thank you.
It's a treat to listen to you. So one thing I want to make a point is definitely the quality of MR in our country that good to establish a focal therapy program. One question I want to ask is, focal therapy is based on the index lesion. Am I right? Yes. The treatment of the index lesion. So I don't know if you have to treat all the lesions or just because MRI is very good to pick the index lesion. So other lesions, I think, doesn't matter much.
Yes, but a biopsy needs to be done and if there is clinically significant cancer detected on biopsy on the contralateral side, which is MRI occult, I think the patient is out of the eligibility criteria for focal therapy.
So these are the things that we are going to deliberate on. Dr. Santosh is going to talk about the clinical relevance of MRI invisible lesions. I just want to hear from Dr. Sadhana. You said that dynamic contrast enhancement is absolutely mandatory for a focal therapy program. And now we are coming up with abbreviated bioparametric protocols, excluding the need for a dynamic contrast enhancement. So Dr. Sadhana, would you answer this question, whether you would let go of the dynamic contrast enhancement phase for diagnosis and planning of focal therapy?
Yes, but with a caveat, if the quality is excellent. So you have to have a place where you can vouch for the quality, and you should have a mechanism to bring the patient back in case, the quality is poor. So just based on bioparametric, no. But if the quality is excellent, yes.
The quality for detecting, I think, any 3 tests, I think they will be. I don't think so, sir.
I think that, can I add it? Can everyone hear me?
Sir, if to understand exact lesions, like how we showed yesterday the kidney tumors with a 3D model, we are working on 3D model for prostate. It's a DTI images we acquire, and it's a AI based development of 3D model. We can overlay even the neurovascular bundle. We can clearly understand in a 3D model where exactly the lesion is there. This will help us to understand the lesion better. It is to educate the patient, as well as to take the biopsy from that. And probably that's going to change the way we understand the lesion and it helps in giving even focal therapy. So three-dimensional understanding orientation will be there for focal therapy. That's going to change the way we understand and we treat these lesions using focal therapy.
I kind of agree with most of the points you have mentioned. As far as focal therapy is concerned, we do need contrast, because if you see the T2 weighted and the DC or ADC, sometimes the contrast shows that the tumor is a little bit more extensive than what the DC, ADC or the T2 weighted. So for margin acquisition, I completely trust the contrast one. The second question is 1.5 Tesla and 3 Teslas. 1.5 Tesla, we usually go when we have patient with hip artifacts, where we have because the signal noise ratio comes into question. When we go for 1.5 Teslas, we have better image acquisition. I think that's what our protocol is, but it's up.
So today, with the new gradients, 1.5 is excellent with the newest gradients. Not some of the older 3T actually are suboptimal. So I really don't go by the Tesla. Certainly, the newest 3T are even better than the new 1.5. But if you have an old 3T versus a new 1.5, use the new 1.5.
We can move.
Protocols and all of our the ma'am is a professor of radiology, the University of Cincinnati, College of Medicine, the Cincinnati VAMC Chair of Quality and Process Improvement, and the Director of Prostate Imaging Program, Midwest Prostate Cancer Center of Excellence. Thank you, ma'am, and please go ahead.
Thank you. Good morning, all. Really excited. I just learned today while they're putting up my talk, I can say that I was excited to hear that this center was the first one to ever use MRI in India. So very nice to hear that from Dr. Oberoi. All right, so I think as we're waiting, yeah, contrast or no contrast has been a problem for a long time, and hopefully I'll cover a little bit of this in my talk. All right, so let's do, yeah, thank you. All right, so we know, as Anurima nicely showed, that MR is really, it's really interesting for me to see when I had to argue with people to get a prostate MRI as to where we are. And looking at this projected forecast for 2033, already MR is going up so high. And primarily it's because now we can do screening with prostate MRI. A lot of good trials going on in that. So there's no question about identifying lesions, et cetera, but the whole idea of screening just changes the game here. And when I look back and how has that happened, I think it's primarily because we've been able to standardize, at least for clinically significant disease, to decrease variation. Started in 2012, then the ACR, American College of Radiology, and now the 2.1 that we have. We've come a long way, but we still have a way to go. So let's go over that. So where are we with PIRADS 2.1? There's been plenty of studies showing validation for 2.1. That's not a question. And it's a 5-point scale. I was discussing with a few of you earlier, where each sequence is graded, and then we have an overall score. So we're really good about 4 and 5 disease, where you see a restriction, you see enhancement, you have no question. And 1 and 2 is normal. The problem is that 3 that we all face with, the I don't know. And I've heard enough people even say, where people are confused, like, oh, call it a 3 and make it a day, just be done with it. We don't want to worry about it. So I think that 3 big factors in this 3. The quality is number 1, as Anurima nicely pointed out. The big other 2 is experience. And many studies have shown that, especially the precision trial. That was a level 1, saying that MRI should be done before biopsy. That trial showed nicely that experienced readers had lower PIRADS 3, less than 10%, and unexperienced were up to 21%. And you add in the idea of biparametric without contrast, it goes up to 39%. So then half the cases are PIRADS 3. So we have to be careful about that. So I think 3 is a different topic, but I just wanted to kind of bring that up. All right, so today we've got this whole idea for multiparametric. Right now, as a PIRADS committee, we have not endorsed biparametric. By the way, there's been plenty of studies, even level 1 evidence, and it's because of quality. And I'll go over some of that. so if we just look at what MPMRI is, I don't need to go into the details of all this, but we have the three sequences, axial, coronal, sagittal. We have diffusion, and how we obtain diffusion. It's more of a radiology stuff that I don't want to bore you guys with, but we certainly want quality. And as Anurima nicely pointed out, that we do have these three sequences. We have diffusion, and then we have contrast. The biggest time sink in all of this is T2 and diffusion, by the way. It's not the contrast. So the whole talk about all the time is, about, let's get rid of contrast so we get, faster images, and let's go over that. And then T1, we do a large field of view to do local staging as well. So I know in India, there's no insurance. In the US, there's insurance, which is a problem because once you get a scan, it's harder to get a second exam, as opposed to Europe, where they do multiple. They'll do a detection scan, they'll do all these different scans. In the US, we do one, and that patient has a harder time getting another MRI. So we do staging at the one time. So I think that would be very applicable to here as well, that you would do all three. And so when we do get this whole multi-sequence exam, we also have to add a 3D T2 sequence, because if we're going to do a fusion biopsy, you need a 3D image so that you can actually see the coronal and sagittal planes better than the FSC T2. So question comes up, why can't we replace this? We just don't have we've not had the resolution yet. All right, so it becomes quite long. And so the problem is scan time and accessibility. And obviously, if we're going up to the volume that we're going to do, we're going to have to cut down somewhere. And also to ensure quality, because the high predictive value, it's not only at a center level. So for instance, we may have different centers with 3 different scanner types. There's a lot of variability in each. Then patient level with prep. We deal a lot with rectal gas, and I'm sure people do prostate MRs, they see that rectal MR, you don't deal with that, but in prostate MR, it's all about the rectal gas. And that diffusion is very susceptible to gas. And so the diffusion is the workhorse, and then that gets degraded. And so those are really real issues that we have to deal with. So we do need focused protocols, but the question is not always contrast or no contrast, because like I said, if you have a multi-parametric for all these sequences and you do biparametric, you have all this, you just remove the contrast, but we really didn't change the time here as much, because typically with these sequences, you have about 20 minutes time, but that's only obtaining the sequence, but the patient time is really 30 minutes. You have to give slot, to get the patient, all that stuff. So you're cutting down about 5 minutes with a contrast. So now we have level 1 evidence that biparametric works great in all these sensitivity, specificity. This was the PRIME trial that was just published last year. There's a big provided here, image quality is adequate, because that is the biggest problem, right? The quality. So they actually only had the best quality they included in this trial. So the problem, you have to look into that. So now there's another thing. It's not just biparametric, it's fast biparametric. So what's that? So you remove all these, and then you also remove the other planes. And so you only have single axial T2 and axial diffusion. That's nice, but the problem is 3. PIRADS 3, especially in the transition zone, you do need to look at the other sequences. So, I think maybe for screening, this is good, but certainly not in this situation for focal therapy. So typically when we do, the biggest time sink, like I said, is diffusion and T2. So if we can manage our time with that, we always have to, in imaging and MR, it's been the problem. The signal to noise, the image resolution, and time acquisition. It's this the trade-off, the triangle trade-off you have to do. If you increase the signal, the image resolution, the signal to noise per voxel signal goes down. And so then you increase time. And so this has been we've been dealing with all our lives with this, but there's now AI that actually helps. And this is where actually it helps. So now we can do this, there's AI in the software, in the scanner itself, that can bypass all that triangle stuff I was telling you about. So you can bypass your resolution, SNR issue with time, and get sharper, better SNR and reduce noise in images. And I won't spend much time except to show you that when you look at conventional image, that's T2 here on the left, and on the right, which is half the time, they look very comparable. So today with the rectal gas motion you have, and you use the deep learning, it's really quite impressive what you can get out of that. This is a patient who had back pain and had spine surgery, et cetera, was moving a lot with the DLR. You can see faster acquisition, better. So we don't need to worry as much now, but these are the newest scanners that have this. Fortunately, all major vendors have this now. Now we're using this clinically right now. What about diffusion? Because that's really where the biggest time sink happens, and it's also the workhorse for imaging in terms of both it's used for peripheral zone detection as well as in transition zone. It can help you upgrade. So even in the diffusion, we can use it helps quite a lot in terms of the decreasing the time and getting good quality images. So now with the focused MR protocol, using these deep learning techniques, we can actually do less than 10 minutes. And if you use contrast, it's 12 minutes. So it's not bad. You can do all 3 planes with contrast and get quite a impressive exam as long as you have good quality. You do have to worry about a couple of things in, and most of the vendors that have already worked through it, but just to kind of know, just like any AI, you can get hallucinatory artifacts, et cetera. And we've had to deal that when we were working with them, but now that the protocols are installed and are being used, they're all, I think all vendors are quite good at that. So I think we can use them clinically quite well. We also do diffusion with the high gradients, like even with 1.5, the newest 1.5 has very high gradients, and we do a multi-B value scan, but now we can post-process. We don't actually have to acquire the high B value. We can post-process and get, I don't want to get into physics here too much, but certain B values are important as per PIRADS, and it's easy to do that post-process rather than acquiring it with just as good quality. And so this is something I've been working for a long time. In 2020 is when we set up these centers of excellence to American College of Radiology. And it's continued to grow. We are now doing it's across the country. Since 2.1, and we get this a lot, since PIRADS 2.1, we haven't done anything since. And this year is it where we're going to come up with all these 4 different areas published. This is something very actively in work right now. The MR quality, the PI-Qual is going to be part of PIRADS now. And we have nothing for active surveillance, as you can imagine. And radiologists, when we're reading this, at least half the scans are follow-ups, right? And we have really nothing, because PIRADS is only for clinically significant, right, for detection. So we're coming up with specifics, just like typical to the liver and the breast imaging. And also for staging, we may be staging just looking at things, but there's really nothing through PIRADS, and we're going to come up with that. And the best part is the post-focal treatment imaging. So I know we have PIFAB and Target, which Target I was actively involved in, but it's still not there. So we've got both those people on the table, and we're coming up with a system that works for everyone. That's going to be also hopefully probably not published this year, but at least part of it will be there. And so really the take-home message is that today it's feasible to do a short 10-minute exam. Obviously, DLR improves workflow efficiency, consistency, and it's important to monitor the performance in a multidisciplinary group. I think that really helps. And I think quality is key. So it doesn't matter if you have 1.5, if you have 3T, and if you're using contrast or not, but quality is very important if you're going to do this. So thank you.
Thank you, ma'am. And it's really great.
Sorry, this is a PIRADS document that anybody online that you can get for all the sequences that you may want to see. You can have examples of them.
So, ma'am, Dr. Raghunath was here mentioning the role of a 3D model and the use of using generative models using AI. One of the questions that I have is that in the current scenario, we are in the stage of training the model. So the 3D model only marks the tumor as we mark it, and it does not have may not have the radical prostatectomy true volume of the tumor to actually tell us how precise the margins or the marking of the tumor. In your experience, which is quite a lot, we know. Is there any role of that 3D modeling to show the tumor location, its predisposition? Does it actually clinically help?
So we've been using started about 8-9 years ago. We were doing the 3D modeling for prostate. 3D printing is another thing that we have done in the past. Unfortunately, that has not really panned out for prostate because of the area that how we're marking it. The invisible disease is invisible, and so it does not really, we mark what we see. And in fact, I know one of the urologists who was using that quite a bit, and the post follow-up, his results were not, anything different. So I don't personally use that anymore.
Yeah, one question, Dr. Sadhana here. Thank you for your talk. So I am very curious to know two things. Working with cutting edge MRI systems and AI coming into the picture. What about MRI occult lesions? Is AI going to help us with picking up, because what is not visible to the human eye
Yeah.
might be visible to AI? Secondly, do we foresee a future where we may actually be so accurate that histopathology may not be required? So I'm not putting them out of the game. It's just that, that's one additional step before we
Yeah.
do things. That's why.
No, it's excellent because for renal, we're not doing, right? So for renal stuff, we have gone further. So yes, MRI right now, it's still work in progress, but a lot of the radiomics we're using, and there's textural analysis. Nothing has panned out as so to kind of completely overdo anything. But I do believe with combining genomics with that, there is a role. And I think AI will eventually, I mean, we can see for almost everything, it may be able to do that. But I think currently we don't have anything like that, but I think certainly there's role. The other part is the MR fingerprinting work that has been done for prostate. I think that is looking into that space as well about histopathology.
Can I ask
Hi,
a question, please?
sorry.
What about restricted spectrum imaging, CEST imaging, Ferromox? The ProstaProgress trial has just been completed. Are they adding any value? Do you foresee them coming into routine use?
Yes, right now it's a separate company, the RSI, and several trials have been done. RSI was started for neuroimaging originally, and I actually worked with them because there was a GE sequence. I think it does have a role. I think, replacing regular diffusion, I don't know, but it certainly has role. If you can use it, I think it adds to it.
What about ProstaProgress? The Ferromox, which is the trial has just been completed using the iron oxide particles.
Yeah, the problem with the iron oxide has been the iron oxide with the liver deposition. And originally there was so much work in that it's unfortunate. Yele Barons, as you know, has used to carry, I think, in his pocket the iron oxide stuff. But it just hasn't panned out, so I don't know yet how it'll be.
The question is about CEST imaging, CEST with the amide proton transfer, where you can see the spectroscopy of the prostate in a different way. Does that help? Do you foresee it coming in?
The only place I can see, and I use spectroscopy forever. I mean, I'm a big spectroscopy person. Even with the best hands, 10% of the data was useless. So I think in mass imaging, that may not happen. But I think where it could be useful is in the transition zone, because that's where we have the biggest gray area.
Yeah, Sadhana. This way.
I have a question. Many of the patients, because of the renal impairment, cannot be given a contrast. And what is the future of the simulated contrast imaging?
What contrast imaging?
Simulated contrast.
Oh.
Yeah. Without giving any contrast.
Yeah. Right now, we don't have any.
There is one recent publication.
Yeah, it's just beginning. I think it's trickling in. Hopefully, something comes through it, but we don't really have enough data to say.
And another question is that most of the problem is MRI is underestimating the Pyrite 3 lesion in the transition zone as a BPH nodules. How to overcome this?
I think the three big things in that space, at least even in the publications, and we know that personally, I know that just doing this so much, is that quality of exam, number one, the experience of the reader, and then location. So transition zone lesions, that is one of the areas. And I think that's where I was saying, some other things such as RSI, perhaps if there's a spectroscopy role, those are the things that will help eventually.
So we'll take last two questions, one from Dr. Santosh.
Hi, Sadhana. Welcome back. Always good to see you. Now, with regards to the PSMA PET, because the Primus score is now, most of the nuclear guys are reporting it. And taking back from the question which was asked earlier, mainly the TZ lesions where the Primus 1 and 2, they are trying to elaborate more on that. So do you have any kind of collaboration at Cincinnati where you're trying to compare the PIRADS with Primus and come out with an AI module which may enhance our pickup rate for the prostate cancer?
No, we don't have anything in Cincinnati, but as a PIRADS group, the committee itself, we have looked into it and considered should we do something, and we haven't done anything about it yet.
Because we did a study of about 80 patients last year, which I presented at Ash Tiwari's meeting. The specificity is quite good. The sensitivity is still not there. But if we combine and have an AI model, it might be something to, I think,
Certainly, I
watch the
think,
space.
yeah, we were thinking of doing something with AI in that space.
Thank you.
Exactly my point. I was just mentioning, I'm from PGI Chandigarh, Dr. Aditya. So what we faced at our center, MRI waiting lists were going up to 1.5 years. So what we started doing, we diverted our patient to PSMA PET CT. The waiting was much less. And we started doing robot arm guided transluteal biopsies for these patients. And the detection rate for these patients who were previously negative on trust guided was the tune to about 84%. I have not brought the data here, but as Dr. Ashwin was mentioning, that can we go to a biopsy-free pathway, not for the focal therapy per se, but maybe for prodigal prostatectomy, combining a multiparametric MRI, PET CT, and targeted biopsy. Maybe eventually we can have that. So that is, what's your take on that? Exactly as he was saying that you can combine the MRI with a PET, where you have the uptake in the lesion itself. So that is.
Yeah, I think there was a urologist, Dr. Bracken, who's now retired in Cincinnati, who never believed in this MR, and then at the end was doing prostatectomy, if I called something PIRADS 5, and it was extraprostatic, etc. So yeah, things do change. So
we have Dr. P.S. Chaudhary's talk on the role of PSMA PET for focal therapy. Maybe he can shed some light. I'll request to move on to the next session, please. Thank you so much.
Thank you for such an insightful and engaging session. This concludes our first session and marks a wonderful beginning to our day 2 of the Geofocal Summit. I kindly request our chairpersons, moderator, and the speakers to collect their mementos from the registration desk. Moving on to the next session, focal therapy, science, selection, and surgical judgment. The moderators for this session are Dr. Prashant Singh, Assistant Professor, Urology, AIIMS, New Delhi, and Dr. Jagdish N. Kulkarni, Consultant Uro-Oncologist, Breach Candy Hospital, Mumbai.
Can you please reintroduce the chairpersons, please?
I would like to introduce the chairpersons for this session. Dr. Anil Vashne sir, Delhi, Dr. Sadhna Verma ma'am, USA, and Dr. Bharat Gupta sir, Delhi. So I'd like the chairpersons to come in the front and have a seat. So we have this very interesting talk by Dr. Abhinav Sidana. He'll be delivering 2 talks back to back. One on ideal patient selection and energy selection for focal therapy, followed by his experience in cryoablation. And these will be delivered online. So can we have the talk? Dr. Abhinav Sidana, he is the Director of Prostate Cancer Focal Therapy at University of Chicago. Very good morning, Dr. Sidana, and good evening for you. Can you hear us?
Yeah, I can hear you. Can you guys hear me?
Okay. Yeah, your slides are visible and we can hear as well. So you can proceed with the talk.
Great. Good morning. I would like to thank Dr. Raval and Khanna, as well as the rest of the organizing committee, for the kind invitation. And I sincerely apologize for not being able to make it to Delhi this time. It is my honor and privilege to be presenting in front of you all today. Before we start my talk, I just wanted to address a couple of things which were discussed in the previous talks. I was not able to speak. I think I was muted. We worry a lot about MRI called cancer, but over the years, I've been doing this for 10 years now, and I was fortunate that Dr. Verma was my mentor and my colleague. the MRI called cancer, I think it's very small proportion. I think majority of it is poor image quality and poor read. So if you get a good MRI and sit with Dr. Verma, or now I'm fortunate to have Dr. Odo at UChicago, majority of the time we are able to visualize a lesion which was previously not read, and there was a biopsy grade group 2 disease. So I think as a focal therapist, I've stopped worrying too much about MRI called cancer. I still do systematic biopsies, and rarely we do find true MRI called cancer, but it's not as common and as prevalent as we used to worry about in the past. Regarding the second thing I wanted to comment was, can we go biopsy free? I think we are getting really close to getting there. There has been a trial from Germany, trial from China, where they did an MRI, found Pyrethroid 5 lesion, got PSMA PET, and patients who were both positive on MRI and PSMA PET, they removed the prostate without doing a biopsy. And every single patient had prostate cancer. There was no patient who had benign pathology. So I think we're almost getting there, and especially I think with something like focal therapy where the morbidity is low, unlike prostatectomy, I think we might be able to adopt that earlier than we can do for prostatectomy. Okay, with that, I will start my talk. These are the disclosures of my talk. And the objectives of this talk are twofold. I'll highlight some key selection criteria for focal therapy of prostate cancer and review the principles of energy modality selection for an effective focal treatment for prostate cancer. What is focal therapy? Focal therapy is a guided ablation of MRI visible and biopsy proven index prostate cancer along with a rim of normal tissue. The goals of focal therapy are to eradicate significant prostate cancer while preserving genitourinary function. Therefore, appropriate imaging and biopsy are essential for identifying patients for focal therapy. I won't delve too much into the rationale for focal therapy because I know that will be covered in the subsequent talks, but we'll start looking at the guidelines and any guidance we have from those guidelines in terms of selection for focal therapy. So if you look at EAU 2025 guidelines, they recommend focal therapy with cryo or HIFU within a prospective registry and with all other ablative modalities as part of a clinical trial, but they do not shed any light on selection of appropriate candidates. On the other hand, NCCN actually does not even recommend focal therapy as a primary therapy for prostate cancer and recommends that focal therapy should only be offered as a part of randomized clinical trial. There are several consensus statements over the last 10 years where the experts have looked into different criteria for focal therapy selection. And most recently, there were Falcon guidelines, which was a Delphi consensus of 250 experts, which provided key recommendation for focal therapy in localized prostate cancer, emphasizing that MRI visible localized grade group 2 to 3 disease and requiring both targeted and systematic biopsies for diagnosis of focal therapy candidacy. So what are the details of imaging and biopsy for focal therapy selection? All experts agree that MRI is the basis for focal therapy selection. I think if there's one single factor which revolutionized prostate cancer management over the last 15 years is prostate MRI. And it has made a disease which was previously visible so that it can be targeted and we can treat the cancer focally. Consensus panels agree that prostate MRI is imaging of choice, and that's primarily because it has superior detection of clinically significant cancer. This table from the landmark JAMA article from NIH demonstrated that prostate MRI detects 30% more clinically significant cancer. And sorry, my slides are jumping for some reason. detects 30% more clinically significant cancer than random biopsy alone, and was the most optimal approach for prostate cancer diagnosis. In addition, this article from NYU demonstrated that not just clinically significant cancer, focal therapy also has great sensitivity in detecting index lesion, and when combined with MRI has great sensitivity in detecting index lesion, and when combined with saturation biopsy, can increase the detection to 96%. In addition, the lesions which are seen on MRI are usually bigger. They are usually solid tumors, and usually they have Gleason score 7 or greater. So the MRI actually helps in detecting lesions which have clinically meaningful cancer, and thus the lesions which are detected on MRI can be targeted to achieve prostate cancer cure. In addition, MRI helps in locating lesions. It helps in determining the tumor volume. Even though the tumor volume is slightly underestimation than the actual tumor volume on pathology slides, but at least it's a good starting point and helps in the management of the treatment planning. In addition, MRI also helps in detection of secondary lesions, which can be accommodated during focal treatment planning, and also provides relationships with other structures, which is very essential in preserving genitourinary function. Once a potential focal therapy candidate is identified on imaging, confirmatory biopsy is needed, and various consensus statements highlight that focal therapy can be performed in patients who have undergone MRI target prostate biopsy, and in patients who would have a standard transrectal biopsy in which the positive codes reflect and are concordant with a high-quality MPMRI. In absence of MPMRI, a full transperineal template mapping biopsy was considered sufficient to perform focal therapy. However, most consensus statements and experts agree that focal therapy should not be offered only on the basis of target-only biopsy or a random 12-core biopsy without an MRI. So who is an ideal focal therapy candidate? So when I select focal therapy patients in my practice, I look at certain patient characteristics and certain disease characteristics. So in terms of patient characteristics, these patients should have appropriate life expectancy. We're treating them for prostate cancer, so they should have life expectancy of more than 10 years to be offered any active treatment for prostate cancer. They should have good functional status, which can be preserved using focal treatments. And finally, and the most important is they need to understand that this treatment strategy has a slightly higher risk of recurrence, and the patients might need repeat treatment, and there is a need for lifelong surveillance. In terms of disease characteristics, we offer focal for patients who have only clinically significant disease with grade group 2 or grade group 3 prostate cancer. It's okay to have benign or grade group 1 disease in the untreated zone. In terms of PSA, we select patients with PSA less than 20, or in cases where the prostate is extremely large in size, PSA density less than 0.2. The one factor which determines focal therapy success, and the biggest and the most important factor, is the disease focality. Patients who have unifocal, unilateral, or anterior-only MR visible disease are ideal for focal therapy. These patients tend to do better than patients who have multifocal MR visible disease, but only Gleason 6 in the untreated zone. In addition, patients should have absence of high-risk features such as extensive extracapsular extension, seminal vesicle invasion, invasion of the urethra, and the disease should be isolated from vital structures like urethral sphincter, midline close to the rectum, or neurovascular bundle invasion. So how do we select energy modality for focal therapy? There are several energy modalities in market now, and we have access to several of them in the United States. But there are several key considerations which help in selection of energy modality. One key consideration is the gland size. While prostate volume is usually not a determinant of focal therapy eligibility, however, the distance of the target lesion from the available energy source can dictate the choice of modality. Take an example of HIFU here. If there's an anterior lesion which is more than 4 centimeters away from the rectum, the HIFU, transrectal HIFU would not be an ideal option in that setting because it would not be able to deliver enough energy to destroy or completely ablate the anterior lesion. Similarly, in case of a prostate where there's a posterolateral lesion and a TULSA-PRO or transurethral energy modality is used, it may not be ideal if the distance is more than 3 centimeters from the urethra. The second factor, and I think the most important determinant of energy selection, is the lesion location within the prostate. Different energy modalities work better in different lesion locations. Take an example of this lesion in the lower left. In this location, the lesion is close to urethra and close to the midline, close to the rectum, and there's some potential of damage to the neurovascular bundle. So in this location, the energy modality which would work best would be something with higher precision like HIFU, because you would like to destroy the lesion but avoid damage to vital structures. On the other hand, in a patient like this, where there's a big anterior lesion, but it's really not close to anything important, urethra is down here, neurovascular bundles are posterolateral, so there's nothing very important here. And so the patient like that can get more imprecise energy modality like cryo and still get a good outcome in terms of both cancer control and preservation of genetic urinary function. Finally, a patient with a very distal apical lesion, in this location, if we adopt a thermal energy modality which works with heat or freeze like HIFU or cryo, there could be some potential of damage to the urethral sphincter leading to urinary incontinence. In this situation, a thermal energy modality such as irreversible electroporation would be better suited because it will cause less damage to the urethral sphincter and preserve patient's continence. Lesion size is another important determinant of energy selection. Whether the target is a 6 millimeter Peyer's 4 lesion, something like this, or a big 2 centimeter Peyer's 5, it can dictate the importance of achieving confluence in the ablation zone. And the reason I mentioned that's important is confluence refers to the merging of individual discrete ablation lesions into a single continuous and solid zone of irreversible tissue necrosis. So the larger lesions like this one require the ability to create larger areas of confluent destruction. Smaller lesions may rely more on precise targeting and ability to control treatment within the prostate capsule. So HIFU works really well for smaller lesion. It works really well for functional preservation because you can control the treatment around the prostate capsule and avoid spread of treatment outside the capsule too much. However, cryo works really well for bigger, larger tumors because the treatment is more confluent and can ablate larger areas of the prostate. However, the treatment also spreads outside the capsule to a significant extent and can cause more damage to neurovascular bundle than what HIFU achieves. Additionally, anything that impedes energy delivery to target lesion can lead to ineffective ablation. Calcifications, seeds, and fiducials in prostate can obstruct ultrasound waves and make treatment with ultrasound-based modalities such as HIFU and TULSA-PRO more challenging and less effective. Surgeon preference for real-time feedback of treatment effect might dictate energy selection. Cryoablation treatment effect can be visualized. Like here, you can visualize it as an ice ball on the ultrasound. TULSA-PRO uses a software and MRI thermometry to ensure optimal temperatures are reached in the ablation zone. On the other hand, modalities such as irreversible electroporation and HIFU do not provide a concrete real-time feedback of treatment efficacy. Finally, availability, surgeon's experience, and insurance coverage are important factors which play into energy modality selection. Is there a best energy source? In my opinion, there's no clear single best option for all lesions locations. All these energy modalities have their own merits and limitations. However, for most circumstances, comparable efficacy can be achieved if we couple an energy source with a preferred lesion location. For example, anterior lesion, cryo, posterior lesion, HIFU. And I think if you adopt energy source based on lesion location, the efficacy is comparable. Impact on functional outcomes is slightly variable between these energy modalities. So this is our initial experience from Cincinnati when we did first 150 cases, and we demonstrated that the pathological failure rate is comparable. It varies from 14 to 20% in these patients. And this includes both in-field and out-of-field failures. And their functional outcomes were comparable too, because we selected patients in a way that their function would not be impaired just based on energy selection. As we previously discussed in the previous talks, targeting accuracy is very important, but in most cases can be compensated by increasing ablation size. And finally, availability, reimbursements, and ease of use will be the main drivers of adoption of different energy modalities. So this is my use of focal therapy energy modalities. We have access to cryo, IRE, TULSA-PRO, vapor, and HIFU at University of Chicago. And I use these modalities for these lesion locations. Cryo, IRE, mostly for anterior. In some cases, TULSA-PRO and vapor. Posterior, I use HIFU. Occasionally, I use cryo for large posterior lesions in patients who do not have good sexual function. For apical lesions, and that's a very tricky location for any prostate cancer management, be it focal therapy, be it surgery, be it radiation, I use HIFU for posterior. And I have found out that even in cases where there's a very distal lesion, doing a unilateral HIFU is a safe option, and patients typically do not get incontinent. IRE I use for anterior apical lesions. For periurethral lesions where I worry about a cancer abutting the urethra, I use HIFU for posterior lesions, and I use IRE for anterior lesions. And for larger ablations, hockey sticks, subtotal ablations, I use cryo and TULSA-PRO. So to conclude, focal therapy is a very personalized treatment option.
Dr. Bharat?
Dial it down for less aggressive cancer and can be dialed up for aggressive cancer. Its prostate MRI's ability to accurately detect and localize clinically significant cancer has potentiated this approach. Selection for focal therapy is done by MPMRI followed by targeted biopsy. Disease focality and disease risk are the two primary determinants of focal therapy, good focal therapy selection. Lesion location and the size are the primary determinants of optimal energy selection. And at this point, there's no clear winner in terms of energy modalities. And I think selecting energies based on availability, based on reimbursement, and ease of use are probably will be the primary drivers of adoption at this point. Thank you for your attention.
Dr. Abhinav, you can have your next talk and then we can take the questions at the end.
Okay. So my next talk is on prostate cryotherapy. And the objectives of my talk are to discuss the mechanism of action of prostate cryoablation, review our techniques of focal and whole gland cryoablation, and review some challenging scenarios of prostate cryoablation. Prostate cryoablation is accomplished using the cryoneedles, which are inserted through the perineum and result in freezing of prostate tissue. Resultant tissue death is multifactorial. Freezing results in intracellular ice, which disrupts cell membrane. Thawing results in cellular swelling, which further ruptures cells. And then freezing also results in endothelial damage of capillaries in the ablation zone, resulting in thrombosis and ischemia, which further contributes to cell death. All these results in coagulative necrosis of the tissue. There are two prostate cryoablation systems available in the market. Both systems have probes which can result in ice ball of like various length and various widths. So to achieve complete ablation of the target lesion, the needles are planned so that the minus 40 degrees centigrade isotherms are at least touching each other. The goal of them is to overlap them by at least few millimeters, but as long as they're at least touching each other, most of the time you're able to achieve complete ablation. The planning can either be done cognitively by the surgeon in axial view, or you can use a newer treatment planning software. This is a screenshot from a Qualys treatment planning software, but most fusion platforms now offer treatment planning softwares for focal therapy, where including cryoablation, where the software itself will guide you for the needle placement. So when I first started using cryoablation for focal therapy, majority of the prevalent data was on focal treatments done cognitively, with a significant proportion of them being hemiablations or hockey stick. They were called focal, but they were a lot of time just hemiablation or hockey stick with cryoablation. Since prostate lesions do not follow anatomic boundaries, do we need to perform focal therapy using some fixed template? Take an example here. The lesion is paramedian or right paramedian lesion. If we perform a hemiablation on this lesion, there will be plenty of margin anterior to the lesion, lateral to the lesion, but not enough medial to the lesion. And so we proposed that the ablation margins should be centered around the lesion, and that can be done effectively using fusion technology. This is our video which we published 6-7 years ago. Back then, the treatment planning softwares were not available, and actually there was no TP guided system which could allow prostate cryoablation. We worked with Artemis system to develop this prototype, and then I think they came up with a commercial attachment. So we did the scan of the prostate and to do a TP fusion, mark the boundaries of the prostate, created a three-dimensional model of the prostate using ultrasound. And then this was superimposed with a three-dimensional model of the MRI, which was first aligned. Rigid registration was done, and then elastic fusion was done to achieve complete fusion. And on this ultrasound, the lesion was already marked by Dr. Verma, and along with the 1 centimeter margin. And using that fusion, we inserted cryoneedles, and we varied the length of the cryoneedle based upon how much ablation zone we needed. And then we monitored the ablation under ultrasound and fusion guidance. We published our initial series of fusion-guided ablation, and every patient either had grade group 2 or grade group 3 prostate cancer. None of them had grade group 1. We demonstrated that the patients maintained their urination, they maintained their sexual function. There was no significant decline in either one of them. And they had significant decline in PSA at 3 months. Then there was slight increase in PSA by 12 months, and the median decline was around 55% at 12 months. Even though we ablated smaller amount of prostate tissue, but since it was done with fusion guidance, we believe that we achieved appropriate margin for these patients, and that was reflected in our results. Our pathological failure rate was only 22%, and this includes both in-field and out-of-field failures, in all the patients who got biopsied. I also perform whole gland cryoablation in a small proportion of my patients. Usually these are the patients who are elderly, they are not fit for prostatectomy, and they are either ineligible or are adamantly opposed to getting radiation for prostate cancer. They have either primary or radiorecurrent disease, clinically significant cancer, but usually bilateral or multifocal, where they're not ideal candidates for focal therapy. As we mentioned in the previous talk, gland size is not a strict criteria for focal therapy. However, it is a strict criteria for whole gland cryoablation. Prostate size should be between somewhere from 15 to 60 gram to do a whole gland cryoablation for prostate cancer. When we perform whole gland cryoablation, we start with an axial view, and we plan needles so they're at least the minus 40 degrees centigrade isotherm between the two needles are abutting each other, and there's slight overlap of that minus 40 centigrade isotherms. And typically, for most gland size, we end up putting 6 cryoneedles, occasionally 8 for larger prostates. Once the needles are placed in axial view, we look up the sagittal view and then plan the length of the needle, which will cause the freezing. And so these needles have variable isotherms, and the length can be adjusted based on a slider. Care is taken to avoid placing these needles too close to the urethra. The closest we can go to the urethra is 5 millimeter. Sorry, not sure why my pager is ringing. Then the ice ball is monitored under ultrasound, and this white line, the hyperechoic line, is actually 0 degrees centigrade, and every millimeter anterior to this hyperechoic line is 7-degree drop in temperature. So this helps you estimate where the minus 20 degrees centigrade would be, which is a lethal temperature for prostate tissue. So what are the few challenging scenarios for cryoablation? First is any patient with prior ablation. So when there are patients who have prior ablation, placing needles can be challenging. Prostates are smaller, prostates are more woody, so getting the needle in appropriate location is sometimes more challenging. The second scenario is larger prostates. In larger prostates, getting the interior needle could be challenging because of interference from pubic arch. In salvage cases, especially for anterior recurrence after brachytherapy, care has to be taken to avoid damage to the pubis, because it can result in a fistula to the urinary tract from the pubis bone. Finally, in case of distal apical tumors, as we previously discussed, cryo can cause a lot of spread of ice ball outside the capsule. So in patients who have distal apical or a bladder-based tumor, cryoablation has to be performed very carefully to avoid damage to urethral sphincter. In terms of periurethral cancer, when we perform cryo, we introduce a urethral warmer to protect urethra from freezing. So in patients who have a periurethral cancer and abutting the urethra, in those cases, cryoablation would not be very effective in completely ablating those tumors because the urethral warmer will serve as a heat sink and will avoid completely ablating periurethral cancer. So to conclude, cryoablation is a very commonly used modality for prostate ablation. Cell death happens due to multiple mechanisms. The primary is rupture of cell membranes and secondary is endothelial damage of the capillaries. For focal cryo, unifocal unilateral disease, patients with MR visible lesion and have good function are ideal candidates. For whole gland cryo, patients who have multifocal disease and they are either not good surgical candidates due to age or other comorbidities, or they are adamantly opposed to radiation, would be good candidates for whole gland cryo. Thank you.
Thank you, Dr. Sidana, for such interesting talks. Now we can have some questions. Hello, Dr. Abhinav. I am Dr. Bharat. I am a consultant interventional radiologist at RGCIRC. So we do the energy part. I think it's almost similar to rest of the body. If you see prostate also, like if you are periurethral, anterior and close to neurovascular bundle. So I would ask some technical questions regarding cryoablation. So we do a lot of cryoablation in the rest of the parts of the body, in fact, kidney as well. So what challenge we face in entirely doing in ultrasound guidance is once the ice ball formation starts, so you cannot see what is happening posterior to the ice ball. So once the ice ball formation, we start the ice ball formation, you cannot see anything what is happening what is happening posteriorly. So I don't know how you make sure where is the urethra. So it gives a posterior acoustic shadowing once the ice ball starts.
In prostate cryo, it's more anterior, right? Because your ultrasound is posterior. So posteriorly, you see ice really well. And that's why I like cryo a lot, actually. So the important structures are posteriorly rectum. So you're able to see ice ball getting up to the capsule. However, you do not see ice ball anteriorly. And I think that's why it's important to plan your ice ball in a way that you're not completely ablating the pubic bone. However, other than the pubic bone, there's nothing much you can damage anteriorly. So as long as your ice ball is close to 1 centimeter from the capsule, at the max, you'll ablate anterior pad over the prostate, but you would not cause any damage. And the posteriorly is where I think you can cause damage, but at posterior edge, the ice ball is very visible. So you can see the ice ball and make sure not damaging the rectum. But yeah, there is way to visualize the entire circumference of ice ball. And in US, Mayo Clinic does MRI guided cryoablation, and they can visualize the entire ice ball. But for more practical purposes, I think seeing only the posterior edge of the ice ball is sufficient.
Okay. One more question. So the protocol of cryoablation is like similar to rest of the part of the body, like we do a 10 minutes freeze, then thaw for around 8 minutes, then freeze. It's similar in prostate, or it's a different protocol?
It's not a fixed amount of freeze. We freeze based upon how much area we want to be frozen, right? So if it's a focal treatment, we're only freezing a small amount of prostate based on fusion guidance. If your fusion is showing this like green bubble, right? Once you have achieved ablation in that green bubble, you can stop freezing. And sometimes it might be 3 minutes, other times it might be 6 minutes. So we freeze based upon how much we want to ablate rather than by a certain time. And then we thaw until all the needles are visible again.
I
So-
think that depends on the system also. Which cryoablation system you are using?
We use Varian cryoablation system, Endocare. It used to be called Endocare in the past. So it has it's not the Boston Scientific, it's the other one.
Yeah. So we have a Boston Scientific one, so that is the reason I was asking.
But even with Boston Scientific, if you're doing prostate cryoablation, you cannot ablate as a fixed time for every prostate. That's why you have an ultrasound, and ultrasound will help you guide the treatment. If your prostate is frozen, stop freezing, right? It has nothing to do with timing. I think you're seeing, if you're doing whole gland ablation, once your ice ball is at the posterior capsule, let it come out 1 to 2 millimeter outside the prostate capsule. I usually stop when my ice ball touches the rectum. So the most posterior edge of the ice ball is 0 degrees centigrade. So when that touches the rectum, then I know my prostate capsule is in minus 20 range. So that's when I stop.
Abhinav,
It might take 8 minutes.
Okay. Abhinav, this is Dr. Rawal, and thanks for your talk. I was wondering, do you irrigate warm saline when you do cryo for prostate, and you do cold saline for hypo to avoid the rectal injury, or just ultrasound probe with a condom is enough?
In majority of the cases, when I do primary cryoablation in patients who have never received any treatment, I do not do hydrodissection with saline. There's plenty of pararectal fat, which allows the safety. In cases when we're doing salvage cryo, in those cases, I used to use warm saline hydrodissection. But now I do, occasionally rectal spacer preoperatively to kind of separate the prostate from the rectum, and that makes the procedure safe. But yeah, only in salvage cases I worry about rectal issues, and we do one of those two things.
Good evening, Abhinav. This is Rishi Nair here. See, there is a very significant overlap in the patients who are ideal candidates for active surveillance and who are candidates for focal therapy. And we also know that MPMRI also 50 to 60% of GG1 lesions are visible on MRI. So when you say that MRI visible lesions, MRI is the main crux for selecting the patients for focal therapy, how much of a weightage you would give on biopsy versus a MRI? Because biopsy, I think, still carries more weightage. Do you give any weightage to the core positivity volume?
I think we believe biopsy should be given more weightage. 5 years from now, I think people will agree that imaging should be given more weightage. I give imaging more weightage. So if there's an MR visible lesion on contralateral side where I'm not planning to treat, even if the biopsy comes back as grade group 1, we do not offer them focal therapy. If there's a grade group 1 which is MR invisible, we offer focal therapy. But if there's a grade group 1 which is MR visible, we don't offer focal therapy, because a lot of time I used to offer focal for them, and I would do their 12-month biopsy. The same lesion, which in my hand was grade group 1, 12-month biopsy would show grade group 2. So there's so much sampling issues with biopsy. So if you have, none of them is complete truth, not imaging or biopsy. But if I have to put more weightage, I put more weightage to imaging than on biopsy.
And do you also select the lesions to be ablated based on the core positive volume? Because a 10% 3+4 would not be the same as 50% 3+4.
So we kind of made it very binary. If you look at my data, there's not a single grade group 1. So if you're grade group 1, you're getting active surveillance. If you have pattern 4, whether you have 5% or you're 80%, as long as it's 3+4 or 4+3, we offer them focal therapy. So we made it very standardized. And yes, however, the patients who have higher pattern 4 disease, they tend to recur more than patients who have a lower amount of pattern 4. But we offer focal therapy for all of them.
Okay, thank you.
Dr. Abhinav, very nice talk. You have all these technologies. Now, new technologies are coming, aqua ablation. Where do you see this, the utility of aqua ablation for organ-confined prostate cancer?
Aquablation is being studied as a phase 3 clinical trial, and UChicago is one of the sites for this trial. Right now it's not approved for prostate cancer, but I think if it gets approved for prostate cancer, I would think it would be great modality to do whole gland ablation. I think it can achieve, and that's what they're studying. They're doing whole gland ablation of aquablation versus prostatectomy, Waterford trial. So if the trial is positive and aquablation gets approved, I think it would be ideal for whole gland ablation for these patients.
Thank you.
I think
Can I give him one
I just
question?
have wanted to add something to something Dr. Sadana mentioned about the grade 1 disease. Now there's good data on MRI, both 5 and actually 15 years follow-ups, that if it's a grade 1 disease and it's visible on MRI, that's the one that's going to progress. So if it's invisible grade 1, yeah, it's not even to worry about.
And to add, I think it's less progression, mostly reclassification. And focal therapy helped me understand that. Before I started doing focal therapy, I did a lot of MRI research. And we published all these articles, though, Pirates 5, 50% grade group 2, other 40% grade group 1. But those numbers are not real, because if you keep biopsying up the Pirates 4 lesion, Pirates 4, sorry, not Pirates 5, Pirates 4, 50% grade group 2 and 30% grade group 1. However, if you keep biopsying the same lesion again and again, they're grade group 2 in that lesion. We just missed them the first time.
So quick question, Dr. Abhinav. I am Aditya Pradhan from Delhi. When you mentioned your data, there was a 22% failure rate at 3 years. So these patients, how are you managing them? Reablating them with with cryo, or are you changing your modality, or you send them off for RT or surgery?
We discuss all the options: surgery, radiation, and ablation. Majority of our patients end up choosing repeat ablation. Around 15 to 20% end up getting either radiation or surgery, and that's patient's personal choice. Very rarely we would really recommend somebody to get radiation or surgery, if the disease progression is too higher grade. So if they have grade group 8 in their at the time of the recurrence, we would recommend them to get radiation or surgery. But if there's only Gleason 7 recurrence, if they are open to repeat ablation, we offer them repeat ablation.
Dr. Sadana, I was listening to your lecture, of course, both lectures, and I see if we have to take a focal therapy program, you've got to have at least 4 different ways. When we have a budget constraints, what should be the priority? Which should be, for our CEO is going to ask us, which is the best, which is going to give you revenue as well as it is safe?
I think when I was opening a focal and I had conversation with Dr. Hash Ahmed from England, and he recommended to have 2 modalities. And I think that's my recommendation to everyone. I think having an access to a modality like HIFU allows you to do precise ablation and actually attracts patient to the program, because you can prove that you can preserve sexual function. And then a modality which is needle-based, either cryoablation or IRE, can effectively treat anterior lesions and also can treat bigger lesions, which sometimes it's difficult to treat with HIFU. So I think around 2 modalities would be ideal, but I'm pretty sure, we are investigating a lot of other modalities. Water vapor therapy is coming. Aquablation might get approved. I think there might be in near future, there might be one modality which might work well for all lesion locations. But at this point, I think 2 modalities are needed to completely treat all lesion locations.
Abhinav, this is Dr. N.P. Gupta from Delhi. Abhinav, excellent lecture. I want to ask you what kind of counseling you are doing with the patient to decide the modality, whether focal or surgical or radiation. Can you tell us the tricks? Because it is very important. You all say the patient will decide. I don't know how he will decide. he will always ask here, doctor, you tell me, you are a doctor, I am not a doctor. So how do you counsel the patient?
So, very interesting and very relevant question. In most patients, especially, I have a busy surgical practice. I do robotic prostatectomy. I do both XI and SP prostatectomy. So for most patients who are in like 60s and early 70s, I do not recommend them one way or another because I offer them surgery, radiation, and focal therapy. I tell them pros and cons of each other. In my entire experience, less than 10 patients have chosen surgery over focal therapy if they're candidate for focal therapy. And when they chose surgery, I did their surgery. I did not recommend them focal. However, older patients, like above 75, and now, a lot of healthy, active 80-year-olds want treatment. In all those patients, I recommend them focal therapy now because I've seen my own outcomes. I think patients do comparatively do really well with focal therapy than radical treatment in that age group. So in those patients, I would recommend focal. But for all other patients, I offer them both options, and majority of them still end up choosing focal.
What about age of 40 or 50? Because
I
we see
do not
patients
offer
in that
focal
age group
now.
also. Sorry?
So I have a lot of like arbitrary cutoffs, and I follow them. And I am pretty sure some of them have scientific rationale, others don't, and you may not agree with them. I do not offer focal for somebody younger than 50 years of age. Having done focal for 10 years, the surveillance burden of focal can sometimes be a lot for these patients. They get periodic MRIs, they get periodic biopsies, and then biopsy results in inflammation, causes PSA to rise up, and then you get more MRIs and more biopsies. And I don't foresee a 44-year-old to get to age of 80 without getting his prostate removed or something else happening. So a lot of time I would actively discourage them from getting focal for that reason. I think mostly just surveillance burden.
Thank you, Dr. Abhinav.
See, in India,
We'll
the
have one last
follow-up is
comment.
a problem and cost of the follow-up also. Because insurance companies are not covering them and they are paying from their own pocket. That is the reason active surveillance have not been very popular in our country. So same problem will come for focal therapy actually.
I think focal has definitely less active surveillance issues. Like the surveillance part of focal is less active than active surveillance. So you'll do less MRIs, less imaging. But when you start treating a 44-year-old, yes, that's a lot of surveillance. That's why, I don't offer them on somebody younger than 50. But if you offer focal for somebody at age of 71, I think it's definitely less burdensome than active surveillance.
So we'll have one last comment and then we'll
So,
close this session.
I'm Dr. Musa. Good morning from Lebanon. With all these minimal invasive techniques, important is the cancer control and the quality of life of the patient. During my consultation for the patient in my country, I can orient the patient on what technique to do. If I will focus on focal therapy, he will be influenced, he will decide for focal therapy. If I will focus on radical prostatectomy, he will do radical prostatectomy. My question is, after doing this minimal invasive techniques, how is the follow-up? How frequently you do biopsies for the patients? And when you decide for radical prostatectomy after minimal invasive treatment?
So I follow them at 3 months, 6 months, and 12 months in clinic visits. Somewhere from 9 to 12-month window, I do an MRI and a biopsy. That's for every focal patients. For whole gland ablation patients, I get PSAs at 3 months, 6 months, 12 months. But they don't get MRI, they don't get biopsy. So less surveillance burden. And then after first year, they get every 6 months follow-up and MRIs every 2 years after that. But no biopsy.
Thank you, Dr. Abhinav, for taking your valuable time out. Have a good night. We'll like to close this session now.
Thank you very much.
Thank
Now we
you.
move on to the live operative session.
Thank you, moderators, chairpersons, and speakers for a very informative session. I request all the moderators and chairpersons to collect the mementos from the registration desk. Proceeding with our next session, live transperineal software-based fusion biopsy with available Indian fusion platforms. I request Dr. Sarbata Kumar Pratihar, consultant uro-oncology and robotic surgery, RGCI Delhi, to moderate the session.
Thank you, Dr. Leela. Very good morning. So welcome you all to our live operative session of today. So we will having transperineal prostate biopsy. We'll be starting in this session, we will having two transperineal prostate biopsy. First, we will go with the BK Medical System. Following will be Artemis system using Fujifilm ultrasound. So today I welcome our chairpersons. So I take the pleasure to invite Dr. Narma Prasad Gupta, who is Professor Emeritus and currently in Medanta, Gurgaon, to chair the session. Along with, I invite Dr. Rishi Nair, Professor AIIMS New Delhi, Department of Urology. I invite Dr. Gopal Sharma, Consultant and Head of Department Urology in Manipal Hospital. I welcome Dr. K. Priyatam, Urologist from Prashant Hospital, Vijayawada. Dr. Harkirat Singh Talwar, Consultant Urologist, Uro-oncologist and Robotic Surgeon from Max, Noida. I welcome Dr. Abhinandan Mukhopadhyay, Senior Consultant Urologist from Artemis Hospital, Gurgaon. I also welcome our friend Dr. Musa, who is Professor in Lebanese University and former President of Arab Association of Urology, to join and chair the session. Thank you. Can you connect to the OT? Hello, Dr. Manohar. Dr. Manohar, can you hear us? So briefly I am introducing the operating team. Dr. Manohar is a chief urology, uro-oncology and kidney transplant surgeon from Apollo Hospital, Bengaluru, and he has a vast experience with MRI transperineal fusion biopsy using the BK Medical System. We have our anesthesia team, Dr. Shagun and Dr. Vivek with us in the OT. Dr. Nikhil will be assisting Dr. Manohar, and we have our own sister Ratika ji assisting with them. I request all the audience and the chairperson to interact with the surgeon. We'll be having the technical person of the BK Medical System also in the OT. So if you have any technical clarification, you can always ask them. Sorry for the delay, we'll be connecting soon.
Meanwhile, if you have the details of the patient,
Yeah,
then maybe just.
can we share the detail of the patient? Audiovisual team, can you put up the slide? So briefly introducing you the patient. So first patient is a 59 years old male. He had a voiding and storage LUTS symptoms for 1 month. He is having no comorbidity and PSA is 9.2 milligram nanogram per ml. So MP MRI was done. Prostate is around 53 cc and he is having 4 Pirates 3 lesions. You can see one Pirates 3 lesion is on the right PZ area, that is a 6 millimeter lesion. This lesion, this is the T2 sequence, this is the diffusion weighted, and this is the ADC and this is the DC sequence. And there is having a Pirates 3 lesion on the left transition zone. This is the lesion. This is around 6 millimeter. And he has 2 more lesions in the mid gland in the transition zone region. Those are also Pirates 3, one in the right transition zone, this one, and another in the left transition zone. Those are around 10 millimeter, 11 millimeter in size.
How many in the audience are doing transperineal biopsies as of now? So quite a bit of centers have started doing it. And how many are doing fusion biopsies transperineally? Almost the same number.
So I think those who are doing transperineal, because they have shifted to fusion biopsy, that's why they have acquired the transperineal technology.
Yeah, maybe. But there are many other centers who were doing transrectal fusion biopsies.
Yeah, we had
of
that
one-
facility earlier. Now for the last 2 years, we are completely shifted to transperineal. Earlier, we used to do transrectal fusion only.
And I believe most of the transperineal biopsies are in India are being done under local anesthesia only, or you are using general anesthesia? So nobody has raised hands. How many are for general anesthesia? Doing only under general anesthesia?
Everybody may be doing
Everyone.
everybody.
No, and how many are doing under local anesthesia? So almost the same number of people are divided. Yeah, conscious. So these used to be kind of limitations earlier why people were not going on to the transperineal, because it requires general anesthesia, it requires a lithotomy position and additional OT table suit is required. But the good side is that you do not require antibiotics at all in transperineal biopsies now.
Mostly who are doing
And the incidence of
transperineal,
sepsis has drastically gone down.
most of the people who are doing transperineal freehand, they actually the transperineal under local, they're actually doing a freehand, non-software fusion.
Yes.
If you need a software fusion grid based, you have to do the GA. You want the patient to complete immobility.
May I ask one more question? How many in your hospitals, who is doing the biopsy? Is the radiologist are doing or the urologist are doing the biopsy? Urologist? All urologists are doing biopsy. Is that right?
So it is like both are doing in most of the places. Most of the places, I would say. I think TMH is predominantly it's done by IRs. Am I right? So it depends on center to center.
No, it depends upon the policy of the hospital also, actually, and where is the machine is located. If machine is in radiology department, obviously radiologists will be doing. If machine is in urology department, they will be doing. because I tell you the history part. In 2002, in All India Institute of Medical Science, and we requested our radiology department to start the 12-core biopsy at that time, standard transrectal 12-core biopsy. And they refused actually because they are so much overworked with their own, because that was a government hospital, clinical work. So they said, no, Dr. Gupta, we cannot do. So we were forced to buy a machine for ourselves. We kept in our ward actually, Dr. Rishi and all, they are still doing there, I hope. And we started doing our own biopsy, 12 core. That is the way we started, learned from them only. And then we are doing.
Generally, it
So
happens.
since 2002, I am doing biopsy, and now 2012, I shifted to in Vedanta. We also don't, we do all biopsy ourselves. Urologists are doing. And we have got the fusion biopsy started in 2012, way back when nobody else was doing. And we have published our paper also. So it depends upon person to person. It depends upon hospital to hospital and center to center.
I mean, if I can add, in
Hello,
UK,
so-
90% biopsies are done by nurses now, not even urologists. So it's just about experience. If you have done enough,
If you
Dr.
train
Jit,
your
we are
nurse or
starting-
technician,
Yeah.
they will be doing.
They
Same
will-
is happening to surgery also now. Even the robotic surgery is done by the technicians,
Flex
So now we are connected to the OT.
90% nurses.
Now we are connected. So we are having some audio problem. So we can see the video input from there, and we have to connect the audio through my phone. Sorry for the inconvenience. Very good morning, Dr. Manohar. We are all listening to you.
Not seeing some audio. We just want to hear what you're trying to say, because we're not able to hear other guests asking questions. So just give me.
So no, in the meantime, we are just discussing about the biopsy methods, transperineal versus transrectal, fusion, what is the general practice. We are just discussing the things.
Hello.
We can hear the audio from the OT. Now it is clear.
Yeah, good morning.
Yeah, Dr. Manohar, we can hear you.
So,
The voice is breaking. The voice is breaking. Hello. Yeah, so we can hear you.
It's somewhere around 9, or somewhere around 8, 19 grams phosphate. So, there was scanning. One second.
The image was previously. Yeah, we can see now.
Yeah, let's go. So, yes.
Can you switch off the light here?
Inside. Almost now. And so the whole implementation has done. What I'm saying to you, we shall have go to the right? Showing the comparing of the prostate and the can market as red pit. contouring of the prostate and keep it, and then next slide. Once we do the contouring of all the lesions, then do the replacing placer. This is a very important step. Yes. Orientation, because sometimes the prostate is very large, the prostate, the rectum goes down, the orientation of the rectum goes down because of the prostate enlargement. Then how the rectum, the contour of the rectum is different. So this is actually what you go where our child actually whatever it goes, it has to be going up line. So what shall we have align the growth along the rectum. So you can adjust it. Then the orientation of the rectum has been put. This is called the virtual probing. We are going to do this virtual and just like that. Once the laser has been done, the contouring has been done. That means this patient has the positioning of the rectum, the rectum put into the particular position, and we can go ahead. So this will be my assessment is that one on the right side, look from the infarcted area there. Possibly there is no restriction of any of the lesion. But anyway, we'll plan for the targeted biopsy because its PSA is high and the patient is young and prostate is very large, 90-gram prostate. So first we'll do a targeted biopsy, and then in this case, I also would like to do a peri-lesional biopsy. Yes, I'll go by the side of the lesion and then take the peri-lesional biopsy because as it is a pre and total lesion. Hello? Yeah? Hello? Professor Datta, can you hear us?
No, you're not here.
Hello, दादा सुनाई पड़ रहा है क्या? Hello, दादा.
No, we cannot hear you. Hello.
Somebody else from the OT can voice is clear. They can just.
Jamish.
Problem issue है.
Hello. We cannot hear you.
वीडियो क्वालिटी बहुत खराब है. फिक्स कर सकते हैं. फिक्स कर सकते.
So, Dr. Ashish, we are taking a break of 5 minutes. We can discuss about the cases or any biopsy related things. Meanwhile, you can set up the audio and video. Is it okay?
I think we are having
We
technical
can,
issues. Let's
yeah,
discuss
let's
theoretical
discuss some theoretical aspects. So, my first question, like if you have a regarding focal point of view, we will having subsequent debates also. So, what biopsy do you prefer? Do you prefer to do only target biopsy or target biopsy, systematic biopsy, target biopsy, perinatal biopsy? What is the vote of the audience? Maybe Gupta sir can enlighten us because he has a huge number of fusion biopsy.
See, as we have already discussed in the previous lecture also, Dr. Sardana has mentioned that you have to do targeted biopsy along with systemic biopsy. That is the current protocol going on, because that invisible lesion, what we have heard in the other lobe, that can be picked up by the biopsy only.
Yeah.
So a combined biopsy has to be done. That is the standard practice at present.
If we can add an element of debate to it. So, yeah, true. That was the standard. You do target plus systematic for all these years. In the latest EAU guidelines, they changed it to target only. And it was done at the behest of Phil Crawford, who is a surgeon in UK. Now, the reason they changed it was because focal therapy was never a standard guideline recommendation. And you almost always pick up significant cancer in the target area. So if you're going to find cancer and your answer is that I will remove the prostate, you actually don't need to go to other areas, because then your management will still not change. It will only increase possible risks of bleeding and infection because more needles are going in. So again, I'll put it back to the audience and answer as well. So if you are going to offer only radical prostatectomy, what's the point of sampling the other parts of the prostate? Because if it's MR invisible disease there, it will be T2. It will not be T3. There is no data to show that these invisible cancers are actually T3. They can be Gleason 3 plus 4 or 5 or whatever, but they are confined. You can do a full nerve spare in that area, irrespective of the Gleason grade there. So what are your views on that?
See, as you have asked a question, but the answer is, we as a clinician, I'm seeing, we have to answer to the patient also. And medical legal point of view, because there is no convincing data that you do not do biopsy and straightway go ahead and do a radical prostatectomy. Suppose histopathology comes back as benign. Then how do you explain all those things to the patient? Things happens, may not be very common. So what I'm trying to say is, in our clinical practice, we do biopsy in every case at present, and then only we decide the line of treatment according to the grade of the tumor.
So you have raised a very pertinent point. So this dilemma about biopsy showing cancer but final histopathology showing benign was actually not that uncommon in the era where even Gleason 6s were getting prostatectomy, because Gleason 6 can do this to you. The current data that we have is that if the biopsy is showing an X grade, in 60% of the cases, the final histopathology will show the same grade. In 20%, it will be worse. In 20%, it might be better. Because Gleason 6s are no longer getting operated throughout US and UK. The numbers are now under 5%, in fact, 1%. So the understaging of Gleason 6 is out of question. But we still see Gleason 4 plus 3 turning 3 plus 4, 4 plus 4 turning 4 plus 3, sometimes hidden pattern 5 coming up. So in your clinical practice, this was a question asked by Shashikant as well. His pathologist is now insisting on doing IHC markers for almost all cases, because they are now using IHC to even differentiate Gleason 3 from Gleason 4, because if it changes management. I don't know, do we have pathologists in the audience? Do we have any pathologists remaining? No. Anyway, so I'll summarize it. The current standard for Gleason 3 versus 4 is still morphology, but there are still some pathologists insisting on IHC. So in your institution, do you face the same situation where your pathologist is insisting on IHC for every case? Anyone in audience?
In my hospital, Medanta, ISC is done in every case.
Every case.
And even the biopsy which have been done outside, and where they are doubtful or something, we send them for second review in our department.
Yes.
And recently I had a patient last week only.
Yes.
They have showed a granular hyperplasia outside.
Yes.
And when we got the histopathology reviewed in Vedanta, it turned out to be the Gleason 3+3, and there were 4 cores positive out of 12. So like that in India, I'm talking of Indian scenario. So biopsies are also done outside, MRI are done outside. So we cannot totally rely on those reports actually, you know. And
Right.
I'll tell you one paper we have published from All India Institute of Medical Science.
Mhm.
The first 180 patients, Dr. Hemal was with us at that time. And we have done radical prostatectomy, and out of that 10 cases, yes, the biopsy was negative for malignancy. And then we analyzed those 10 cases, why this has happened actually, you know, like that.
Right.
So there were some where there is a focal of prostatitis.
Yes.
There were some other kind of minor pathology was there, I don't remember.
Right.
But paper is already